Welcome to the deep dive. Today, we're plunging into a really specific yet incredibly important area of veterinary medicine, equine metabolic alkalosis.
It's a fascinating one.
It really is. Our mission, as always, is to take the source materials you provide this time, some really dense but interesting vet texts on this particular challenge, and just boil them down.
Yep, find those key aha moments.
Exactly. Give you that shortcut to being properly well-informed without having to wade through everything yourself.
Sounds good.
So, just at a high level, what are we talking about? Equine metabolic alkalosis. It's an acid-based disturbance, right? The horse's blood pH goes up.
That's the core of it, primarily because there's an increase in plasma bicarbonate.
Okay. And you mentioned it's less common than metabolic acidosis, the opposite problem.
That's true, you see acidosis more often, but alkalosis, when it pops up, can be a really significant clinical issue for the horse.
And there are some weird twists, right? Like, I remember reading their blood is alkaline, but their urine might be acidic. How does that work?
Yeah, that's the paradoxical aciduria we'll get into. It's pretty counterintuitive.
And the treatment often involves just simple saline, salt water.
In many key cases, yes. That chloride is vital. We'll definitely unpack why.
Great. So we've got this picture. Elevated pH, too much bicarbonate. Let's get deeper. What's actually happening inside the horse's body to cause this?
Right. Understanding the pathophysiology is key.
Yeah.
So normally a horse's blood pH is quite tightly controlled, say between 7.35 and 7.45.
That's the normal range.
Exactly. In metabolic alkalosis, that number climbs. It goes above 7.45. And the main reason is that bicarbonate level, the HCO3, normally around 24 milliequivalents per liter.
Okay.
But in this condition, it gets significantly elevated. Often well above 30. That's a big jump.
A really substantial increase.
Definitely. Now, the shift towards being too alkaline, it typically comes about because of two main things happening, and often they're actually working together.
Okay, two main mechanisms. What's the first one?
The first is pretty straightforward conceptually.
Okay.
The body is somehow gaining bicarbonate.
Gaining the base.
Right, but the most common way this happens in horses isn't direct gain. It's actually by losing acid, specifically hydrogen ions, H+.
Losing acid. Okay, that sounds a bit backward when we're talking about becoming more alkaline. How does that work?
It does seem counterintuitive, but this is where equine physiology, especially the gut, plays a huge role. The number one culprit is a significant loss of gastric acid, hydrochloric acid, HCl.
From the stomach.
Exactly. Think about conditions where the horse is refluxing large volumes of stomach contents for a prolonged period.
Like proximal enteritis, that inflammation high up in the small intestine.
Precisely. Proximal enteritis, or duodenitis, jejunitis, as it's sometimes called. Or think about small intestinal obstructions where everything backs up. Even severe gastric ulcers can contribute.
So the stomach's losing all this acid. What happens then?
Well, the cells in the stomach lining, the parietal cells, they make that acid, but here's the key. For every hydrogen ion, H+, they secrete into the stomach, they release a bicarbonate ion, HCO3, into the bloodstream.
Ah, okay, like a balancing act.
Exactly. We call this the alkaline tide. Normally, that secreted acid gets neutralized or reabsorbed further down in the intestine, so it balances out. But if you're losing massive amounts of that gastric acid through reflux,
then that bicarbonate just keeps building up in the blood because the acid isn't there downstream to balance it out.
you got it. That bicarbonate accumulates and boom, metabolic alkalosis.
Okay, that makes sense. Is that the only way they lose acid?
No, the gut is the main one, but horses can also lose acid through their kidneys. This often happens because of certain diuretics.
Like medications.
Yeah. Furosemide is a common one. It's a loop diuretic. It makes the kidneys dump more water and salt, but it also causes more hydrogen ions to be lost in the urine.
So losing H-2 in urine means retaining HCO3 in the blood.
Exactly. Acetazolamide is another diuretic that can sometimes play a role, partly by causing potassium loss, which indirectly affects acid handling.
And I guess, theoretically, you could give too much bicarbonate.
Yeah, that's possible. We call it iatrogenic veterinarian-induced, maybe giving too much sodium bicarbonate solution intravenously. Or, very rarely, a horse might ingest something alkaline, like antacids, but that's uncommon.
Okay, so that covers mechanism one. Gaining bicarbonate, mostly by losing acid. What's the second mechanism?
The second one is called contraction alkalosis. This is a bit different. It happens when the horse loses a lot of extracellular fluid volume, think dehydration, but without losing a proportional amount of bicarbonate along with it.
So the fluid volume shrinks, but the bicarbonate amount stays relatively the same, meaning its concentration goes up.
Precisely. The remaining bicarbonate just gets more concentrated in the smaller fluid volume.
Where do you see this happening?
Well, again, severe dehydration from that gastric reflux is a big one. Also think about prolonged sweating, especially in endurance horses. Horse sweat is interesting, it contains large amounts of chloride and potassium. Losing that fluid and those specific electrolytes can lead to contraction alkalosis.
So sweat loss contributes too.
Definitely. And even some types of diarrhea can cause it, depending on the fluid and electrolyte composition of what's lost.
Oh.
In all these cases, the kidneys sense the low fluid volume.
And they try to conserve fluid.
Right. But in doing so, they also ramp up bicarbonate reabsorption and hydrogen ion excretion. So the kidney's attempt to fix the dehydration actually makes the alkalosis worse.
It's like a vicious cycle. The body's trying to help, but inadvertently digs the hole deeper.
That's a good way to put it.
I also read something about losing chloride through saliva. Can that happen?
Yes. It's less common, but it can contribute. Conditions like tyolism, that's excessive drooling, or dysphagia, difficulty swallowing, maybe from esophageal problems. If they're losing a lot of chloride-rich saliva, it can factor in.
Okay. And low protein. Hypoalbuminemia.
Also a potential factor.
Yeah.
Albumin and other proteins act as weak acids in the blood. So if you lose a lot of protein, the relative balance shifts slightly towards alkalinity. It's usually a smaller piece of the puzzle, though.
Got it. So the alkalosis starts because of acid loss or fluid contraction. But why does it stay? Why don't the kidneys just fix it by getting rid of the extra bicarbonate?
Ah, that's the crucial part, the maintenance factors. The kidneys should excrete excess bicarbonate. That's their job. But they fail to do so, or can't do so effectively, because of a few key problems that are usually present along with the alkalosis.
Okay, what stops them?
First, hypovolemia, that volume contraction or dehydration we talked about. When the body needs to conserve fluid volume above all else, the kidneys will reabsorb sodium. And to maintain electrical neutrality, they often reabsorb bicarbonate along with that sodium, even if bicarbonate levels are already high. Fluid volume takes priority over acid-base balance.
So survival first, acid-base balance second.
Pretty much.
Yes.
Second critical factor, hypokalemia, low potassium. This is really important. When potassium levels are low, the kidneys try desperately to conserve potassium.
Makes sense.
But the mechanism they use involves exchanging potassium for hydrogen ions in the kidney tubules. So to save potassium, they end up kicking out more hydrogen ions into the urine.
Which means they reabsorb more bicarbonate back into the blood, worsening the alkalosis again.
Exactly. It's this tight link between potassium and hydrogen handling in the kidney. You see low potassium in horses that aren't eating anorexia, sometimes with kidney issues themselves, or, again, with diuretic use.
Okay, low volume, low potassium. What else?
The third, and arguably the most consistently important factor, especially with gastric loss, is hypochloremia, low chloride.
We mentioned chloride loss with reflux and sweat.
Right. Chloride is the main negatively charged ion, the main anion, in the extracellular fluid. When chloride levels plummet, like when you lose loads of hydrochloric acid from the stomach, the kidneys face a problem. They need to reabsorb sodium to maintain volume, but they don't have enough chloride to reabsorb with it to keep things electrically balanced.
So what do they grab instead?
Bicarbonate. They reabsorb sodium with bicarbonate instead of sodium with chloride. This allows them to save sodium, but forces them to retain bicarbonate, perpetuating the alkalosis. You'll find low chloride, often dramatically low, in almost every significant case of metabolic alkalosis from gastric loss. It's a hallmark.
Wow. So those three, low volume, low potassium, and especially low chloride, are what keep the alkalosis going.
They're the key maintenance factors. Without addressing them, especially the chloride deficit, it's very hard for the kidneys to correct the problem.
Okay, that paints a much clearer picture of the mechanisms. Given all that complexity, how do vets actually spot this? What are the signs, and how do you definitively diagnose it?
That's a great transition. Diagnosis relies on putting together the clinical picture with the lab results. The tricky part is that the clinical signs themselves can be pretty vague.
Not specific to alkalosis itself?
Often not. They're usually more related to the underlying disease causing the alkalosis or to the electrolyte disturbances, particularly the low potassium.
So what might you actually see in the horse?
You might see things like muscle weakness or just general lethargy, tiredness. That's often linked to the hypokalemia.
Low potassium making muscles weak.
Right. You could also see muscle cramps, fasciculations, or tremors. Again, that could be the low potassium. Or sometimes it's related to a decrease in the active form of calcium, the ionized calcium, which can happen in alkalosis even if total calcium is normal.
Interesting. What about breathing?
This is one of those paradoxical things. Logically, to compensate for alkalosis, the body should decrease respiration to hold on to CO2, which is acidic, and lower the pH.
Right, respiratory compensation.
But often, you actually see an increased respiratory rate to chypnea. This might be driven by pain from the underlying condition, like colic, or maybe low oxygen levels if the horse is really sick. So the underlying disease can override the body's attempt to compensate respiratory-wise.
Okay, so faster breathing doesn't rule it out. Anything else?
Yeah, severe electrolyte imbalances, especially that low potassium, can really slow down the gut. You might see signs of gastrointestinal ileus, decreased gut sounds, maybe mild colic signs just from the lack of motility.
And neurological signs.
Less common than with severe acidosis, but yes, in very, very severe alkalosis, you could potentially see some neurological signs. But usually, the weakness and gut issues are more prominent.
So the signs are a bit all over the place. It sounds like lab tests are absolutely crucial then.
Absolutely indispensable. You can suspect it based on the history, like a horse with massive reflux, but you need the lab work to confirm and quantify it.
And the gold standard is?
Arterial blood gas analysis. That's the definitive test.
What does that show you?
Okay, number one, elevated pH. It'll definitely be above that 7.45 threshold, often higher. Number two, elevated bicarbonate, HCO3 tolerance. That's the primary metabolic problem, remember. So it'll be high, often above 30, sometimes significantly higher.
The high bicarbonate driving the high pH?
Exactly. And number three, you'll usually see an elevated PCO2 the partial pressure of carbon dioxide.
Wait, high CO2. Isn't CO2 acidic?
It is when dissolved in blood, yes. This elevated PCO2 is the body's attempt to compensate. It's trying to retain CO2 by breathing a bit less effectively.
Oh, right. The respiratory compensation we mentioned, even if the horse looks like it's breathing fast for other reasons.
Precisely. The body tries to create a mild respiratory acidosis to counteract the metabolic alkalosis. There's even a rule of thumb. For every 1 MEQL increase in bicarbonate, you expect the PCO2 to go out by about 0.5 to 0.7 millimole Hg, roughly.
Okay, so high pH, high bicarb, and a high-ish PCO2 trying to compensate.
That's the classic blood gas picture. And often the total CO2, or TCO2, measured on a standard chemistry panel, is used as a good estimate of bicarbonate. If that's high, it strongly suggests alkalosis.
What about the electrolytes? We talked about them being maintenance factors.
Checking serum electrolytes is non-negotiable. It tells you so much about why the alkalosis is happening and how to treat it. You'll almost always find hypochloremia low chloride, especially with gastric loss. It's usually the most striking abnormality.
The missing onion.
Exactly. You'll also very commonly find hypokalemia low potassium due to those kidney losses and potassium shifting into cells.
Yeah, sodium.
Sodium, hyponatremia can be low too, often just from fluid loss or if they've been given fluids low in sodium. But sometimes sodium can be normal or even look a bit high relative to the very low chloride.
Okay. And calcium.
Important to check ionized calcium. Even if total calcium is normal, the alkalosis itself can decrease the ionized active fraction, potentially causing those muscle tremors. Magnesium can also be low, particularly if there's significant sweat loss involved.
Got it. Any other useful lab tests? What about the anion gap?
The anion gap is usually normal or sometimes even slightly decreased in straightforward metabolic alkalosis.
Why is that?
Well, the anion gap reflects unmeasured anions. In alkalosis, you often have low albumin, an unmeasured anion, and high bicarbonate, which isn't part of the standard AG calculation. If the anion gap is high, it's a red flag that something else is going on too. Maybe a coexisting high anion gap metabolic acidosis from something like lactate buildup.
Okay, that's a useful check. Now, back to that urine thing. The paradoxical aciduria. How does checking urine help?
It can give you some really interesting clues.
Yeah.
As we said, despite the blood being very alkaline, the urine might actually be acidic, a pH below 7, sometimes quite low.
And that's because?
Because the hypovolemia and hypokalemia are forcing those kidneys to dump hydrogen ions, acid, in order to save sodium and potassium. The kidneys' priorities are messed up, essentially.
So finding acidic urine in a systemically alkalotic horse is a strong clue about those underlying volume and potassium problems.
It really is. And another key urine finding, low urine chloride. In the common chloride-responsive alkalosis, the body is desperately trying to hang on to every last chloride ion, so the kidneys will reabsorb almost all of it, meaning very little appears in the urine, often less than 10 or 20 MEQL.
Finding low urine chloride tells you the body needs chloride.
Exactly. It points you towards chloride-rich fluids being the right treatment approach.
This is fantastic. We've got the causes, the maintenance factors, the diagnostic picture. So the really critical part now, how do we fix it? What's the treatment plan for a horse with metabolic alkalosis?
Right, this is where it all comes together. Treatment has a few key pillars. Pillar number one, absolutely essential, address the underlying cause.
Can't just treat the numbers, you have to fix the root problem.
Precisely. If you have ongoing massive gastric reflux from proximal enteritis or an obstruction, you must stop that acid loss. That means gastric decompression, passing a nasogastric tube and siphoning off that reflux continuously.
Get the acid out before it causes more problems.
Yes. If it's a surgical obstruction, obviously surgery is needed. If it's proximal enteritis, it's intensive medical management. Fluids, drugs to help gut motility, prokinetics, pain relief.
And if it was diuretics causing it?
Then you need to stop the diuretic if that's clinically feasible for the horse's other conditions.
Okay, stop the cause. What's pillar number 2?
Pillar number 2 is the cornerstone, fluid and electrolyte replacement. This is where we correct the dehydration and those crucial electrolyte deficits.
And this is where the saline comes in.
This is exactly where isotonic saline, 0.9% sodium chloride, NaCl, becomes the fluid of choice for the most common type of metabolic alkalosis in horses, the chloride-responsive kind.
Why specifically saline?
Because it delivers exactly what the body is screaming for, chloride. Saline contains 154 mg/L-EQL of both sodium and chloride. Giving that chloride is essential to replenish the deficit.
And once chloride is replenished,
The kidneys can relax. They no longer need to hold on to bicarbonate just to balance sodium. They can finally start excreting the excess bicarbonate and correct the pH. Plus, the saline corrects the hypovolemia, the volume contraction.
so it fixes the volume and provides the key anion.
Exactly. And you might need large volumes, especially severely dehydrated horses or endurance athletes. The critical point is the fluids must contain adequate chloride.
What about other common fluids, like lactated ringer solution, LRS?
That's a really important point. LRS is generally contraindicated in metabolic alkalosis
Why? It's used all the time.
because the lactate in LRS gets metabolized by the liver into bicarbonate. So giving LRS can actually add more bicarbonate and make the alkalosis worse. It also has less chloride than saline. So saline is definitely the way to go here.
Good tip. Simple saline is key. What about the potassium deficit?
Also crucial. You absolutely need to supplement potassium, usually it's potassium chloride, KCl, added to the intravenous fluids. Typically, you'd add something like 20, maybe up to 40 MEq of KCl per liter of fluids. But you need to be careful.
Why careful?
You only start adding potassium once you're sure the horse has adequate kidney function and is producing urine. And you shouldn't run potassium in too fast, especially at higher concentrations, because it can affect the heart.
So monitor the horse closely, especially the heart, if potassium is very low or you're giving a lot.
Yes, cardiac monitoring is recommended in severe cases.
And calcium. If the ionized calcium is low,
If the low ionized calcium is actually causing clinical signs like those muscle tremors or severe cramping, then yes, cautious intravenous administration of calcium gluconate can be given, usually slowly diluted in fluids.
okay. Are there ever times when just fluids aren't enough? Like really severe cases?
Yes, though it's rare. If the alkalosis is extremely severe, say the pH is above 7.6, and it's life-threatening or not responding well enough to saline and potassium, there are specific acidifying therapies. But these are reserved for critical cases.
What are they?
Things like ammonium chloride or arginine hydrochloride given intravenously. They provide chloride and also generate hydrogen ions as they're metabolized, directly lowering the pH.
Sounds serious.
They are. They have to be given very slowly and carefully monitored because they can cause toxicity if given too fast. Even more rarely, in extreme situations, dilute hydrochloric acid, HCl itself, can be infused. But that's really a last resort, usually done only in specialized ICU settings via a central line with intensive monitoring. It carries significant risks.
So fluids are the mainstay, but these other options exist for the very worst cases.
Correct. And then, of course, managing complications is key. If there's ileus, correcting the electrolytes, especially potassium, is vital. Maybe using prokinetics, addressing pain, ensuring good supportive care.
And monitoring throughout treatment.
Constantly. You need serial blood gas analyses maybe every 6 to 12 hours initially in severe cases to track the pH and bicarbonate. You need to keep checking electrolytes, sodium, potassium, chloride. Watch the horse's clinical signs. Are they brighter? Is their gut motility returning? Are they starting to eat or drink? And, crucially, are they producing adequate urine? That tells you the kidneys are working and the fluid therapy is effective.
It's a very dynamic process managing these cases.
Absolutely. Constant reassessment and adjustment of the plan.
So bringing it all together, what's the outlook for a horse diagnosed with this? What's the prognosis?
That's the million-dollar question, isn't it? And the honest answer is, it really, really depends on the underlying cause.
Not so much the alkalosis itself, but what's driving it.
Exactly. If the cause is something relatively transient, maybe mild gastric reflux that resolves quickly with decompression of fluids, or maybe alkalosis caused by diuretics that are stopped and you correct the fluid and electrolyte imbalances promptly, the prognosis can be quite good. The body can recover well once the insults are removed and balance is restored.
Okay, so prompt treatment of simpler causes is often successful. When does it look worse?
The prognosis becomes more guarded to poor if the underlying disease is severe, persistent, or difficult to resolve. Think severe, unrelenting proximal enteritis or a strangulating small intestinal obstruction that's been going on for a while, causing major bowel damage.
Makes sense. The primary disease dictates a lot.
It does. Also, if significant complications develop like that severe ileus that just won't resolve, or secondary laminitis or acute kidney injury from the dehydration and poor perfusion, that obviously worsens the outlook. And if the alkalosis itself is extremely severe and persistent, leading to profound, hard-to-correct electrolyte disturbances, that's also a bad sign.
Especially that low potassium.
Yes, severe uncorrected hypokalemia is particularly dangerous. It can cause life-threatening cardiac arrhythmias or profound muscle weakness to the point where the horse literally can't stand up. That carries a very poor prognosis.
So the critical takeaway seems to be speed and accuracy.
Absolutely. Prompt diagnosis, using that blood gas analysis and electrolyte panel, is key. And then initiating aggressive, targeted fluid and electrolyte therapy, especially getting that chloride in with saline when needed, is absolutely essential for managing equine metabolic alkalosis and giving the horse the best possible chance of recovery.
What a deep dive this has been. We've gone from understanding that initial alkaline tide in the stomach
To the weirdness of paradoxical aciduria.
and landed on the almost surprising importance of just simple saline because of that critical chloride ion.
It really highlights how interconnected everything is.
It does, and hopefully understanding these specific details gives you listening a much richer, more practical grasp of equine metabolic alkalosis than just reading a summary. That's the goal here, right? That shortcut to really getting it.
Yeah.
So here's a final thought to leave you with. We've seen the remarkable precision needed, especially with fluids and electrolytes, to nudge this specific acid-base balance back into line. Considering that, what might this deep dive tell us about the broader, incredibly delicate dance of acid-base regulation in general and how finely tuned it is to, well, pretty much every major system in an animal's body? Something to ponder. Thanks for joining us on the deep dive.